Hello, everyone. Welcome to Lymphedema Conversations. This is something that we are initiating with today's webinar, and the inspiration behind this was that as Executive Director of the National Lymphedema Network, I'm privy to having lots of wonderful, insightful conversations with industry and therapists and leaders in the field. And some of these conversations don't really have a place in a conference setting, let's say, or a CEUable or CMEable forum like a webinar. So we created this as the ability to provide you with this information and let you in on our conversations so that you can have more insight and make a more educated decision about various topics and things related to lymphedema therapy. And today we're going to start with pneumatic compression. So I'm happy to welcome Eric Ansart. He is president of Liverpress US Distribution. And the only thing that we're going to say is that, the conversation is not sponsored by Liverpress. We wanted you to have an opportunity to get to learn more about pneumatic compression. So again, we hope that you get a lot out of this. Eric, what I'd like to do before we actually formally start with like the questions related to pneumatic compression, I just want everybody to have an opportunity to get to know you a little bit. Sure. And I think that it was interesting in one of our recent conversations that we discovered that we both read the same book. It's by Keith Ferrazzi, Never Eat Alone. And so I can share with you how I came across it. I basically just went into a Barnes & Noble and just randomly chose a book. It has a nice catchy orange jacket. Yeah. Then I read the title, and then I thought it was really interesting, and so I bought it, and it turned out to be a very pleasant surprise in terms of it being all about relationships and the importance of your network and how to take care of people, because you can really help each other. So I'd like to know what you got out of the book.
Yeah, first off, thank you so much for putting this together and the opportunity to be here today. So. Yeah, I remember that book very well. It was at a pivotal time in my life. I was it was probably, I guess, 2008, 2009, somewhere in that range. I have to look at when it was actually published to make sure that it's right. But it was right in that time frame because I remember what I was going through. And I had just gone and listened to Jim Collins, a prolific author. He's written Good to Great and Built to Last and a number of other books. And in the discussion, he was talking about how important relationship is. And I remember walking away from that conference, and he was talking about how whether you are, an athlete or in business or in your personal life, how many times what ends up shaping the success of an individual are the people that they know, the relationships they develop. And I remember I picked that book up specifically because of that. And I was reading through the book, and really what I took away from it was I had to do a better job at being in contact. I just realized life gets busy, things get busy, and I was missing the opportunity of people that were very important to me in my life. Sometimes I would realize it was weeks, months before I had reached out to them. And I think that's just the nature of kind of being in the world that we're in with everything. There's so much going on. I'm a father of 2 young children, married to an incredible wife, run a great organization, and and then between that, hobbies and everything else, sometimes things get squeezed out, and what you don't want to lose are those pivotal relationships that you have with individuals. So yeah, it was a really great book to read at the time, and it's something I've passed on to other individuals as well.
Thank you. Yes. I remember just thinking that, one of the takeaways for me was that when you're in your network and you basically just help each other out and you don't keep track of favors, right. You just constantly help each other achieve your mission and your goal. And ultimately you just constantly elevate everyone,
yes.
together. And I think that was a really nice collaborative thought. And so I really enjoyed the book. I'd like for you to share with us, what your journey was like leading up to becoming president of Limphopress.
Okay. Yeah, I'd be happy to do that. So, I graduated college in the early 90s. I went to University of South Florida, actually, with the intentions of being a physician. I was pre-med. There's probably a lot of people are. You meet a lot of pre-med majors. It's not many people who actually make it all the way through. But I was pre-med, and then in my junior year, I had an opportunity to get involved with a outreach organization. It was up in the Philadelphia area, and it really just spoke to my heart. So I had been in the Air Force prior to that. I was actually using my GI Bill to pay for going to college. I ended up transferring up to a school in the Philadelphia area, and I became a outreach pastor and minister for a lot of troubled youth. And I spent about 11 years, graduated school, stayed in it up until the early 2000s. And I just had a heart for helping young people who had a tough upbringing. So I did that until the early 2000s. In 2004, 2005, things started to change with the organization, started to change some of my own interests and desires as well. I got married in 2005, which was married an incredible woman. I'm very, very happy, and I married up. So we got married in 2005, and I realized that I needed to change my profession for the sake of being able to support a family and do some of the things. So I started looking at a bunch of different avenues, and then I was working, and in 2007, I think everybody will remember, we were just starting the Great Recession. So the economy really started to change, and at that time, I had this pivotal conversation with an individual who really introduced me to the world of lymphedema. He's still a good friend. They had run an organization, a DME organization, for almost 25 years at that point. And they introduced me to the concept of lymphedema. They were offering garments, wraps, compression pumps to patients with lymphedema. And he asked me if I wanted to start getting involved in the education and sales side of that. And I took the opportunity. I was excited to. And it really changed my life because it gave me a place as an outlet where I started to see the impact in people's lives. I remember going into patients' homes early on. I used to go into probably 20, 30 patients' homes every single month. I would help them, understand the device, help them with some questions and things like that. I wasn't a clinician, obviously, but I had the experience with the equipment that we were providing. So, and to go into patients' home and actually see them crying and saying, why didn't I know about this earlier? It has had such an impact on me, and I realized it was something that I wanted to continue. So, fast forward a little bit, 2009, I got involved in more of the administrative side of the organization. And then in 2015, we approached Liverpress and said, we think if we could use the model of providing better education to the patients, better follow-up and education to the physicians, that we might be able to impact more patients and do a better job representing Liverpress. So in 2015, we started Patriot Medical. Patriot Medical is now the exclusive distributor of Limphopress around the country. And I took on the role shortly after that as president of the organization. And it's been an incredible opportunity. I've had the chance to work with some amazing business owners. So as a distributor, we actually work with about 11 different regional providers. So in each geographic region, we have, Arizona Vascular in Arizona, OrthoKinetics in California, Medical Solutions on the East Coast, Stillmead down in Louisiana, Pink Ribbons. We have all of these great companies, Core Medical right there in the middle of the country covering the Colorado and Omaha markets. And it gave me an opportunity to really help them from a business perspective, but stay involved in helping people and helping patients. So it's been a real passion project. Well, it's a job, obviously, but it's something that I really think it speaks to something deep inside me that I enjoy.
Thank you, Eric. So, you've been in the industry, specifically in pneumatic compression, for a long time. Can you maybe tell us your understanding in terms of the evolution of pneumatic compression from the time that the first pump or the first pneumatic compression was made and until now?
Yeah, absolutely. So Lymphopress, some people don't realize that Lymphopress has actually been distributed in the US for 40 years. So in a lot of ways, we were around in the very beginning. There are manufacturers that predated Lymphopress. So in the 60s and early 70s, there were a couple of manufacturers that I won't name just because they're not around any longer. But, those devices really they were based on an understanding, and the compression garment industry in a way was same, in that they recognized that when a patient stood in a pool, there was a graduated compression that just naturally occurred, where the patient received, up to 100 millimeters of mercury in a 6-foot pool down by their feet. And then as each atmosphere moved up, they provided less pressure. So it created this natural gradient. So a lot of the garment companies, or the first garment companies, recognized that and started to develop the technology. And then the devices started to follow. Now, Liverpress has always created a graduated multi-chamber device, but early on, before Liverpress, there were devices that came out that were kind of single sleeve chambers. So it was one leg sleeve or one arm sleeve. It would inflate, and there were definite problems with that we recognized over time. And through the evolution of the product and continued development and technology changes, we started to recognize that in order to really provide the best patient or therapy for the patient, we couldn't use a single chamber sleeve, because when we did that, we created these odd pressure points that sometimes caused retrograde flow or flow in the wrong direction. So the device industry started to change and come out with multi-chamber units. Lymphopress in the early 70s came out with a 10, 12 chamber unit that actually provided gradient compression, and on top added the technology of having overlapping chambers and overlapping cells. That's a technology that we still maintain today, that all of our chambers overlap each other by 30%. So there's this consistent flow throughout the chamber. But there's been this evolution of products over time. And Liverpress has always led on the leading end of that. We've kind of pioneered a lot of these, even to the ability of now being able to provide compression over the abdominal and genital area. We have specific chambers that impact those areas. Obviously, that's a very difficult condition to treat, and we are able to provide products that are specifically geared to treat genital and abdominal lymphedema, as well as understanding the need for axillary compression and providing chest wall compression if you're treating a patient's arm. It used to be that we just provide an arm sleeve that went up to the patient's bicep, and these patients would sometimes develop fluid underneath the armpit or in that deltoid area. And we're able to kind of change that by providing better therapies that provide more comprehensive care.
Thank you very much. Before we continue, is there a nuanced difference between using pump versus pneumatic compression, or is it equally in terms of meeting?
Really, it's the same. I mean, it's interesting. We're all kind of lumped into this world because of coding and reimbursement. So, the devices are coded E0651 and E0652. Those are the technical codes determined by PDAC. They are given certain reimbursement by Medicare and commercial insurances. And, a lot of the terminology just is different by sometimes what device companies want to call themselves or what therapists and clinicians have coined them over the years. There are some companies that like to try to separate themselves and say they're not a compression pump, but the reality is we're all compression devices, and whether we're termed pneumatic compression device, pump, lymphedema pump, it's the same technology.
Thank you very much. So I've been a therapist for 17 years, and my understanding in terms of how pneumatic compression's role evolved over time is such that originally, lymphedema clinics had only lymphedema pumps, and patients would come into the clinic, they would be put on the pneumatic compression, and then they would leave, and that was the entirety of the therapy. Right. Then it transitioned to having only the hands-on CDT. And then now there's more of a blend where some clinics recommend it and some others don't. Can you comment on why it's not universally well received, or why some clinics use it and why some clinics don't?
Yeah, absolutely. So I think what you touched on is really important, in that when pneumatic compression got started, it was used in the hospital. So patients would check into the hospital, they would be there for 2 to 3 days, and sometimes the therapy was coined like a pump down session, meaning the patient would come in with significantly uncontrolled edema, and the patient would be, put on a catheter and monitored with medical, with devices and monitors and things like that. And they would lose a significant amount of weight and a significant amount of edema in a very short period of time. That was like that for a long time. And interestingly enough, there's actually a couple of articles that are out there that were from the 80s that showed that was a fairly successful way to treat some of these patients. Even with one limited session, the patients would come home and have long-term benefit and result. But we all recognize that was not the best way to treat these patients. Lymphedema or chronic edema, regardless of how it comes about, it's all lymphatic in nature. It doesn't happen in 3 days, and we shouldn't try to resolve it in 3 days. It's kind of like going on a binge diet and thinking that's the best way to eat. The reality is we need to be able to provide more measured therapy in a more controlled environment. So coding changed, and when coding changed, the device became available for patients to use in their own home. And with that, it brought its own, challenges, but it also really opened up the opportunity for patients to be able to use these products in their home and manage this condition when they need it. I agree with you. There was a progression, and I remember my first NLN meeting. I think it was 2008. It was in San Diego, the first meeting that I went to. And I literally remember standing there and watching therapists kind of walk around me like we were, anathema. And there was this sense that pneumatic compression was just, not the right thing to do with patients. Gratefully, we've evolved. We've evolved as a product. I think the research has come out. A lot of therapists and clinicians have now grabbed hold of that research and started to be more inclusive in adopting pneumatic compression. But I think part of the reasoning why therapists and clinicians as a whole didn't use it for a period of time stemmed from some of those early days, and maybe just a misunderstanding that pneumatic compression was going to somehow displace them. And the reality is there is no way that any device can displace the incredible work that a therapist does. I mean, it's so much more than what you do with your hands. It is the education you provide. It's the skincare. It's the cheerleading. It's the empathy. It's having somebody that you can go and talk to about a condition that you've suffered with your whole life. You've probably even seen your family members, mother, father, grandparents suffer with, and there was never an answer. So therapists are incredibly important, and no device is ever going to replace that. We are simply an adjunct therapy. We're a tool in the toolbox. You have your manual processes, you have your garments, and you have pneumatic compression. And together, we all work together to provide the best care for the patient.
Thank you very much. So one of the prevailing views from clinicians and the reason why they don't prescribe pneumatic compression is the concern for proximal congestion, where patients will use the pneumatic compression and then there will be the development of genital lymphedema, breast-chest lymphedema, truncal lymphedema. Can you comment on that?
Yeah, absolutely. I think first we need to just recognize that if a patient is susceptible to genital edema or chest wall edema, they have this, they're more likely to develop it whether the patient is receiving CDT and MLD, whether the patient is wearing compression garments and wraps, or a patient's using a device. So it's not specific to the device itself. It's an understanding that these patients have this condition that we need to be aware of, and we need to tailor our therapy accordingly. So from a pneumatic compression perspective, we have definitely adapted over the years, right? Early on, we didn't, those things just weren't part of the technology. But now our devices offer therapy that does bilateral compression, includes the genital and abdominal area, and actually does decongestion of the more proximal areas before it goes down into the other areas. So while we always recommend having a distal hold in our compression, making sure that there's no reflux going in the wrong direction, it's quite common today to have devices that actually provide that more abdominal compression or axillary chest wall decongestion prior to using the device. So there's definitely been a change in technology, and that's just kind of as we've changed as the understanding of the condition has changed. Just like therapists change their procedures and processes, we do the same thing.
Thank you. So, when we prescribe manual lymphatic drainage for a patient, we take into consideration, obviously, the patient's history. We look at which areas are affected, which areas are of compromise, so that we can avoid certain areas. Does your process, or when a patient is recommended to receive pneumatic compression, are those considerations also factored in before you prescribe a specific sleeve to the patient?
That's a great point. And the challenge is sometimes the answer is no. Not that we don't ultimately get to that conclusion, but sometimes we'll have maybe a clinician that's not as familiar with lymphedema prescribe a device, and the patient hasn't been to see therapy yet. So what we try to a lot of times do is be that conduit. If a patient comes to us and they haven't received therapy, we'll try to connect them with a therapist in the area to make sure that they're receiving that care. And we also try to be that educational source. The reality is there's been some, recent editorials that have put out in the last couple of years that have shown that the average 4-year medical school physicians get less than 30 minutes of education on lymphedema. Now that's changing gratefully, and I think more and more clinicians are aware of it. It's come to center stage where, 10, 15 years ago when I got started, many physicians didn't know about it. I remember going into one of my first homes talking to a patient. The patient called the doctor, and the doctor called me and said, "Why did you tell the patient she has lymphoma?" And I said, "I did not say that." So there's misunderstandings, but I think the reality is we need to be that conduit and that education point. So when we recognize that a patient, whether we go into a patient's home, and this happens often, we'll go into a patient's home or call the patient, and we'll find out that there's some complexity that wasn't initially, brought to our attention. We'll go right back to the office and make sure that we are resubmitting for authorization for the product that's correct for that patient, if that's what's needed. Or we'll talk to the therapist, or sometimes it's going back and educating a primary care or internal medical physician that it just isn't aware of some of the conditions that we are able to treat, or maybe they're just not aware that we have the flexibility of garments to be able to treat patients like that. One of the things that comes up a lot is patients with morbid obesity, they won't even fit into standard garments. So we have devices, like we have a product called the Pod. It's like a large sleeping bag that provides compression between the legs and around the entire body, and it's designed for patients that can't fit into standard garments. Many therapists and doctors aren't even aware that we have that. So, it's really an educational effort on our part to go back and talk to the doctor and make sure we're providing the right equipment for the patient.
Thank you. Can you tell us, how is a sleeve decided upon? Is it you? Is it the therapist? Is it the doctor? And is there ever a situation where there's a conflict?
Yeah. So the answer is, ultimately we live in a world where the payers end up dictating what patients get. That's not always actually most often that's not the best situation. So we do a lot of work to qualify patients. I mentioned earlier our network of providers. Each one of those providers has an entire team inside of their office that is calling insurance companies and advocating on behalf of the patient to get the best product for the patient. But there are times where a provider or a payer will come back to us and say, well, that patient doesn't qualify for that, or their benefits don't allow for them to receive that garment. And in that situation, our job is to go back and have a conversation with the patient, with the therapist, with the clinician, and come to a consensus on what is the best product for that patient. So there are times where the wrong product is selected. Ultimately, our goal is to get to something where we're all in agreement that this is the right solution for that patient. Sometimes that decision is made from a financial perspective. Sometimes a patient the insurance company doesn't cover a specific piece and the patient can't afford it. And what we end up doing is working out some effort where the therapist treats the trunk area with, biker shorts and we teach the patient how to do manual massage, and we are doing, thigh-high compression sleeves. And we're kind of creating a solution around that specific patient. But typically our goal is to make sure that it's collaborative. We're all on the same page, and the ultimate effort is to get the right patient or right product for the patient.
Thank you. For the next question, before I actually ask it, I think it's important just to clarify the terms. Compliance is something that I have always known to be something that has taken on like a negative connotation, and it should never be used. And so really the more politically correct term is adherence, or the patient's ability to adhere to a program. And so my question is, what do you think is necessary for a patient to be set up for success as it relates to pneumatic compression?
Yeah. Boy, that's a big question, because I think that is really pivotal for a patient's success, because, we all know, regardless of how great a piece of equipment works, if it's sitting in a patient's closet, it's not going to do any good. So, when we talk about adherence or compliance, we've always taken the viewpoint that it is our job to make equipment that is easy enough to use so that patients want to use it. So I think that's the first starting point, is to make sure that the equipment is simple to use. And it can be simple things like our products have donning and doffing straps. So there's a strap. If a patient can't reach all the way down to their feet, they can grab a strap and pull the sleeve up to their thigh. That makes an incredible difference for a patient who has arthritis or maybe is obese and can't reach down to their feet. So we make, simple things like that. Also, making sure that our equipment, while we have a lot of functionality, you can change pressures and cycles and all of these different things. When the equipment is delivered to the patient, it is delivered with a therapist recommended therapy, and it's locked to that mode. So if the patient receives it, and all they have to do is push a button, and they receive the therapy that the therapist recommended. So there's that side when you talk about adherence, about making sure that the equipment is easy to use. I've walked into homes, I've talked to patients, we probably all have seen this, where I walk in and there's a box in the corner with tubes and hoses and everything hanging out of it, and the patient's never even taken out of the box because it was difficult to figure it out. So we've eliminated that by providing in-home deliveries, virtual deliveries, where we go over this equipment with the patient, show them how to use it, and there's an incredible response from patients when you actually do this in their own home. Because when you educate a patient in a clinic or in a doctor's office or in a therapist's office and they try it, sometimes there's a gap between what happens there and then what happens when the patient gets home. If a patient has to walk home with a product and then put it in and plug it in, sometimes that can be too much of an effort. So what we'll do is we actually go into the patient's home, set it up for them, show them how to use it. And when they use it in their own home and they see how well it works, they become a little more attached to the success. So that's another piece to it, right? So we start off with making sure the equipment is easy to use. Then we move to making sure that the patient is educated to the benefit of it. And then the last piece, and I guess I would throw this out as kind of a challenge to our community, is that we have to do a better job. And I say we, I guess I should say as clinicians, I would ask that we do a better job of encouraging patients when they get the equipment. I've heard too often patients will tell me, well, yeah, the doctor said it might work, it might not. It's a last-ditch effort. We'll see what happens. I don't know about you, but for me, if that's the message that I'm receiving, I don't go home with a ton of enthusiasm to try to use this equipment. So, I think we've seen a change as technology has changed, as research has changed. More and more clinicians are getting on board with recognizing the benefit of this. But if we instruct patients with that understanding, patients walk away with a much broader, deeper belief in the fact that it's going to work for them. And that ties incredibly into their long-term, usage. So if we make easy products, we instruct the patient, and then as the clinical team, we encourage them and believe in the technology that it'll work, I think together we can do a really good job in helping patients with adherence.
Thank you. Can you perhaps talk a little bit about the general successes with pneumatic compression? Is there any statistics that you can, are there any statistics that you can share or um, anything like that in terms of like, would you say that pneumatic compression is more often successful than it is not? Um, can you
Right.
comment?
So I think there are a couple pieces to this. First off, when we talk about lymphedema, sometimes, especially in a setting like this, we talk in broad sweeping strokes, and then lymphedema kind of gets all lumped into this one bucket. The reality is lymphedema is, we're only in that viewpoint because sometimes we're reimbursement or code driven, right? So I-89.0 is this code for secondary lymphedema. So there is a ton of different conditions that all fall within that bucket. But to say that a 70-year-old patient who's dealing with chronic venous insufficiency that has led to lymphatic failure is going to deal with the same challenges and issues as a 40-year-old mother of two who's dealing with breast cancer-related lymphedema, it's just not the case. I mean, those two patients, we want to treat them equally, we want to care for them equally, but they're going to have very different paths, and they're going to have different tools that are necessary and different pressure treatments and cycles and all of that. So I think the first thing, if we're going to answer that question honestly, is to look at the different conditions. If we look at phlebolymphedema is primarily a vascular related issue where there's a failure of the venous system, and then the venous system starts to overwhelm the lymphatic system, and in time can actually destroy it through bouts of cellulitis and other things that can occur. But with that patient, they typically end up in a vascular clinic or in a wound care center. And in that setting, we do have some statistics. You know, Dr. John Lantis at Mount Sinai just finished a poster presentation at the SAWC where he showed that there was significant edema reduction, there was wound healing in a group of 10 patients, which was the first cohort that went through. In a group of 10 patients, 9 of them had chronic wounds related to phlebolymphedema that all resolved in that short 2-week stint. So there's some dramatic results when we talk about edema reduction and wound healing for a phlebolymphatic patient. When we talk about a patient that's dealing with breast cancer-related surgery, you know, what we can tell you is that there have been studies done in the early 2000s at Stanford that actually showed they broke patients, upper extremity breast cancer-related patients, into 3 categories. They gave them standalone CDT, they gave them standalone pneumatic compression, and then they gave them the combined therapy. And what they found over a period of time when they measured their success is that the patients who had both therapies did the best. So, and to me, that really speaks to the fact that Liverpress is not a standalone therapy. It really is a combined therapy. It's a tool in the toolbox that should be widely utilized for, regardless of the condition. We just, phlebolymphedema, breast cancer-related lymphedema, congenital primary lymphedema. The trick is to modify the device to treat the condition properly. But I think all of those different conditions all fall and or all show very good success rates.
Thank you. Can you please comment on how pneumatic compression compares to bandaging compression versus compression that's received from compression garments?
Yeah, absolutely. So first off, back to that toolbox concept, right? We recognize that with pneumatic compression, we provide a great therapy for reduction. But when the patient takes their leg or arm out of that sleeve, they have to use a garment. They have to use a wrap. You know, it's kind of that concept of providing a dam. We might cause reduction, but there has to be something that maintains that reduction and continues it throughout the course of the day. Unfortunately, a patient can't walk around in a pneumatic compression device. There's been a lot of attempts to create mobile devices, and none of them have worked effectively because you have to have a comprehensive therapy that covers the feet, the ankles, the entire leg, and you just can't ambulate with a situation like that. So the device is made to really collaborate with compression garments so that a patient can maintain that reduction throughout the course of the day and use the device mornings, evenings as needed to cause reduction. I like to think of this, I always have this kind of analogy or this little story of your typical grandmother. We all have them. I have, very proud of the grandparents from my children and the grandparents that I had. And, you think about them going to watch your children's baseball game. It'd be great if they wore their compression stockings, but typically most don't. So it's a hot summer day. It's 98 right now where I am in Denver, Colorado. So it's a hot day. Grandma goes to watch the baseball game. She decides to go in shorts with no compression socks. She goes home. Her legs are now swollen. If she has no device, the typical response would be, it'd be wonderful if she were to call her therapist and say, hey, what do I do? But most patients don't do that. What they end up doing is they end up suffering through the next couple of days, couple of weeks, and then they end up either with uncontrolled edema or ulcerations and having to go back in a more of an intensive phase of therapy. If that same patient had received a Limphopress device, they can come home, they can use the device, they can receive the benefit of the reduction, and then put their leg right back in the garment that they wore the day before and continue with the maintenance and improvement. So, I think there's a difference between these research-oriented pieces of study and real life. And gratefully, I think compression garments, pneumatic compression pumps are successful on both sides of it. But I think practically speaking, we need to look at real life for patients and realize that patients need tools because life throws curveballs at you and you need to have the tool to be able to manage it when it does. I'll throw one last piece into this just because I think it's relevant, is when you look at the documents that have been written by Susie Eman and Robin Bjork, the STRIDE documents and others that are, I'm sure there's co-authors that I'm not mentioning, and I apologize. But when you look at those articles, they all show, or at least my understanding is that when you look at the dynamic compression, that is where patients get a lot of impact. Meaning when they wear a compression garment, it is the difference between the resting pressure and the active pressure. And when there's a big gap between those patients do really well because those garments are designed to, maybe when they're walking, they're providing 50, 60 millimeters of mercury pressure, and then they're dropping down into the low 20s or 30s. So there's this big gap. And that dynamic is what's creating the benefit. That ebb and flow is creating the benefit for the lymphedema patient. And with Liverpress, in 2017, we did some research with Dr. Melissa Aldrich. We used some technology that was made in Houston by Eva Sevick and Dr. Rasmussen, I believe. We went down there and we did some research with them where we were able to take clear sleeves and we injected IC green dye into lymphedema patients, into the affected leg of a lymphedema patient. And we were able to see that when the compression cycle was going on, not only did we create flow, but that flow created lymphatic recruitment, it created improved lymphatic velocity, and it improved the frequency of the lymphatic flow. And the incredible thing to me was, first off, it was amazing to just see. If you haven't seen the images of IC green working in a lymphatic leg, it's definitely worth seeing. But not only did we see it while the patient was wearing the device, but after an hour of using the device, we turned the device off but left the cameras on. And for an additional hour, the patient continued to see increased lymphatic flow and velocity return. So, Lymphopress has been shown to improve lymphatic recruitment. And I think a lot of it has to do with that same ebb and flow that we talk about when we talk about garments. The fact that we're able to pump at, use pressures at the 40 to 45 millimeters of mercury on the high side. And then Lymphopress is the only device that will provide that compression. And then on the downside, drop below 10 millimeters of mercury. And that dynamic between the high and the low is what allows for The pressure will actually provide for some of the interstitial movement, kind of like you take a dry sponge and dip it in the water and turn it upside down. The water just moves through all those little nooks and crannies and comes out the bottom of the sponge. Well, in the same way, when we provide compression, fluid moves through that interstitial tissue space up towards the more proximal area. But more importantly, is when we release the pressure, is where we see all those lymphatics open up and they suck in the proteins, they suck in the lymph fluid, they suck in those micro or macromolecules that we want to have removed through the lymphatic system. So it is that dynamic. It is the dynamic of the pressure and then the release that actually causes, or I believe, results in the benefit that we see. And I think that is both on the compression garment and on the pneumatic compression side of therapy.
Thank you, Eric. So, I feel as though, again, just to let everybody know, what we were trying to do today with Lymphedema Conversations is basically recreate a conversation that Eric and I have already had. And so we're just trying to make sure that we got all the pieces in. And I think we covered everything, Eric. The only thing I wanted to give you the opportunity to maybe speak about is there anything else in terms of lingering misconceptions related to pneumatic compression that you would like to clarify?
I think the only thing that I could think of, and we may have touched on this a little bit, is just the misconception that in some way pneumatic compression is designed, or the goal is to displace manual therapy. And I know we talked about this earlier, but the reality is there is no way that we can replace a therapist. We can't replace your care, we can't replace your love, we can't replace your hands, we can't replace your education. We are a tool in your toolbox, and we are entrusting that you recognize the benefit and pass that along to patients. Sometimes I've heard therapists say, well, I use pneumatic compression when patients are really compliant or adherent, but I don't use compression on my non-adherent patients because I'm afraid that they'll use it as their only form of therapy. Well, personally, I hope that isn't the care that I would be given, because when we talk about adherence, the goal is to be able to provide the treatment that the patient is capable of doing. So granted, there are times where pneumatic compression ends up being the primary role of therapy because maybe the patient's not able to do the different things, or they're in a rural setting where lymphedema therapy isn't as available to them. So our job of educating a therapist to be a team and to work together to treat those difficult conditions, the obese patient who may not fit into a regular sleeve or is unable to receive the benefit of standard MLD. We need to work together to be able to solve some of these bigger problems. And I guess our hope would be that you would recognize that we are a team player with you in a much bigger goal of helping these patients.
Thank you so much. So we do have a few questions. The first one, I'm actually really curious to learn the answer to as well, which is it still the case that insurance companies require that conservative therapy fail before approving pneumatic compression?
Yeah, so I hate that word fail, but unfortunately, in some ways, that is the language that insurance companies and specifically federal payers like Medicare and things like that, they use. I think the understanding of what we need to think about is we're not talking about your therapy failing. What we're talking about is the patient's inability to manage this condition without you. So when they get to the end of their treatment with you, if they're unable to manage their condition ongoing, then that is a failure of conservative therapy, meaning the conservative therapy doesn't meet the need for the patient's ongoing management. So while I hate that word, I think what we need to better understand is Medicare and a lot of the commercial payers all follow that same process. That if a patient comes in day one and we begin, you may not say day one, this patient's going to need a compression device. Liverpress may not be applicable for all of your patients. But if day one you start documenting with an understanding that you want to make sure it's an option for you, then you begin your therapy by recognizing and writing down elevation, exercise, the compression that you're doing, you document it starting day one. If 28 days later that patient is still unable to self-manage, and every time you send them home, you see them coming back and they've regressed a little bit between treatments, or you send them home for a week and they come back and you've seen significant change, those are patients that are failing the conservative care. Or maybe we should change that and say the conservative care is failing them. And at that point, documenting that and saying that you've attempted elevation, exercise, and compression for a 28-day period, and the patient, their symptoms are still remaining. Maybe they came in at stage 2. Maybe they were a severe stage 2 and you were able to lessen some of that severity. But at the end of 28 days, they're still in that stage 2, which we know is a very serious stage. I mean, that's a serious condition. If a patient has that much edema and that much fibrotic tissue, we don't want to let them go on and just assume they're going to self-manage after that without a Liverpress device. So to answer your question directly, or the question of the attendee, yeah, we do have to show that conservative care hasn't been effective for the long-term management over a 28-day period for most providers.
Thank you. There's another question on ostomies. Can Limphopress or can pneumatic compression be used in the setting of ostomies, nephrostomies, and other lines and tubing?
So I can't talk for all the other devices because I know a lot of them don't have this ability. This is a unique feature of the Limphopress device. But Limphopress is actually designed with a zipper that goes through the middle abdominal area that is designed to be able to take an ostomy bag through that and to prevent it from being inside the garment for compression. It was specifically designed with that in mind so that we could treat patients with those conditions. Additionally, we do have sometimes where maybe in an arm a patient has a port or something like that and we don't want to compress over that. Limphopress's technology, we have the ability to go in, so you can do it on the device itself, or we also have a Bluetooth technology where the device itself syncs to the pump to your phone, and you can change the therapies on your phone. You can do it on the device as well, where you can turn specific chambers off. So if there's a port up in the axillary area and we don't want to compress over that area, we can compress chambers 1 through 10, skip over chamber 11 and go into chamber 12. And that was designed to be able to, one, accommodate patients like that, but also patients who may have painful ulcerations and we don't want to provide pressure over that area. We can skip that area, and then as the problem starts to resolve, which it usually does quickly, we can then turn those chambers back on for long-term therapy.
Thank you, Eric. Another question is, can pneumatic compression help patients with lipedema and subsequent the development of lymphedema?
Well, that's a great question. There's so much that we don't even know about lipedema, right? It's such a developing conversation. We've got people who are really on the front edge of this, like Dr. Karen Herbst, who's doing research around these things, and there are teams, FDRS and other organizations that are really trying to understand what lipedema is and how we best manage it. But the reality is what we've recognized is there's typically a lymphatic component to lipedema. There's some lymphatic involvement. We know it is an inflammatory condition that is fatty tissue, but there's usually some lymphatic involvement with lipedema patients. So on the edema perspective, we are able to help some of the reduction when a patient is dealing with, the lymphatic piece of lipedema. But lipedema is much more than just edema reduction. Lipedema involves typically painful, sensitive areas. It creates mobility issues. And what we have found is that Liverpress can address a wide array of those different aspects. So we did some research about 2-3 years ago overseas where we were asked to come in, and it wasn't regarding lipedema at the time. It was, for another condition. But the hypothesis was that if you provide sustained compression over a large surface area, that it would reduce pain. And when we did that with our Lymphopress device, we actually created a special cycle where we could provide sustained compression. The patients all reported a significant reduction in pain. It's very similar to if you bang your thumb with a hammer, you grab your thumb and you hold it down and it makes the pain go away. I'm not a clinician or a scientist, but I think so take this with a grain of salt. But I think the pain receptors basically get overwhelmed when we squeeze that, they kind of shut off, right? So what we're able to do with Limphopress is by providing compression over a patient's extremity with lymphedema, we've been able to show anecdotally, and we're looking at research around this as well, but we've done it with at least half a dozen patients, where we provided them a device, and they've all reported some edema reduction, but more importantly, they've reported that they have a reduction in pain and they have an increase in mobility. And what we've found is, and this is what our clinicians and our doctors that we work with are telling us, is that if we can improve some of the reduction, if we can reduce pain and we can increase mobility, then the patient's long-term success goes up significantly because, one, they get more optimistic and hopeful about the future. Second, their increased mobility and decreased pain allows them to start ambulating, getting out, walking, maybe getting involved in an exercise program and other things. And all of those things help with their, the mental component, the psychosocial component of lymphedema, as well as the very physical components of lymphedema as well.
Thank you very much. Another question is, we've spoken about the benefits of pneumatic compression for lipedema and lymphedema, but do you find as though pneumatic compression has a place in other settings, like even in the normal healthy patient?
Boy, that's a really interesting question, because there is this whole component that in the sports arena, right? So a lot of athletes will actually use pneumatic compression. We saw this first years ago with Lance Armstrong. He was using a device in the Tour de France between runs, between segments. He was using a pneumatic compression device, and the thought at the time was that it would help pump out that lactic acid buildup that happens with heavy sports involvement or high strain. But right now, a lot of the teams, a lot of the professional teams that are out there actually use Lymphopress devices that are labeled recovery pump for the sake of, for the commercial market or for the retail market. But they're using these devices to actually increase recovery and speed up recovery between exercises. So there's definitely a component with the ultra healthy athlete using these to get rapid recovery. I will tell you a big piece of the world that really doesn't use our device right now, but probably should be and could be, are patients who've had knee surgeries or being, or going into surgery like that. There's a high correlation between patients who've had, knee surgery and developing some type of thrombosis that eventually down the road can end up causing some type of venous insufficiency or edema-related condition. And if we are able to manage the edema prior to surgery, we can get the edema out. Surgeons have a much higher success rate of being able to treat and do the surgeries without having the issues of dealing with the edematous leg. And then additionally, if we use it afterwards, we've shown this with DVT devices that are out there, that we're able to prevent some of those thrombosis by providing pneumatic compression. So it's kind of a slightly different category of usage, but it's definitely within the scope of treatment.
I definitely have considered that. I think that predominantly what you see in the hospitals after surgeries is the Venodyne pumps, right? And so, I think the idea is there. Do you think that it's a matter of cost, perhaps? I think that the idea has been thrown out there, but what would be the barrier to making that transition from the Venodyne pump to a more sophisticated pump?
So I think it's one need, right? So when you're talking about such a large number of patients, I'm sure there's cost involved in there that I won't speak to. But you've got such a large need, such a large group of patients, and only a smaller percentage of them actually need significant treatment. Most of them just need something to create consistent flows. So when you're talking about a DVT type device, they're crucial, and we've even seen this with the outbreak of the pandemic and COVID, where patients who are non-ambulatory and sitting around, even in their own homes, DVT rates have increased over the last few months because of things like that. So our bodies are made to be active. We're made to be moving and blood flowing. And when we don't do that, things stagnate and things like embolisms take place. So I don't know exactly what the barrier to adoption would be to moving to a more technical device, but I know there are devices out there that are kind of a hybrid between what you would see with your very basic DVT devices. And in fact, Liverpress makes some more advanced DVT products that take on some of the technology of a lymphedema device that fit in that space. There are other manufacturers that do that as well. I'm not sure exactly what the barrier is. I'm sure cost has something to do with it, but that's outside of my privy.
Thank you. So we're running short on time, but this is an easy and quick question. Is Limphopress available in Australia?
So it is. Many people don't recognize this, but Limphopress is actually distributed in 40 different countries around the world. So inside of the U.S., which is probably the majority of the people who are watching this today, there are a couple of different devices that are available. Without naming them, you probably know them by name. But when you step outside of the U.S., Limphopress is distributed in 40 different countries and is really recognized as the leader in pneumatic compression. We've pioneered this technology for 40 years. We're distributed in over 40 different countries around the world. And we try to take that technology and bring it back to each of those countries, for our market back to the United States. And we're providing input from Germany and Australia and Japan and all of these different markets. We're taking that input and we're putting it into our devices. But we do have distribution in Australia.
Thank you so much, Eric. So just to wrap up, I just wanted to, again, let everybody know that this lymphedema conversation was not sponsored by Liverpress. It really, again, was born out of the idea that we wanted to allow for our community of lymphedema practitioners, patients with lymphedema, to get as much information as possible from all different perspectives. And in this case, it was Eric's views on pneumatic compression. So his views are not necessarily representative of the official views of the NLN. However, I would say that the NLN does strongly believe that everybody should have as much information as possible from multiple perspectives so that everybody can make an informed, educated decision, whether you are a clinician who's educating your patient or whether you are a patient making decisions for yourself. We do believe that you should be empowered to make those decisions, and in order to do that, you have to have all the information from all sides and not a skewed, biased view of things related to lymphedema therapy. So hopefully together we can move lymphology forward just by being empowered with information. I would, however, like to thank Eric for Limphopress's gold sponsorship of this year's conference in October. Just like this conversation here, our goal with the program for this year's conference is to basically bring forth and highlight some of the topics that typically do not get the spotlight. So, for example, genital lymphedema, torso lymphedema, breast-chest lymphedema, how much pressure do you need when you do manual lymphatic drainage, pneumatic compression, again, we have a whole session on that as well. And so, we would love to have all of you there, so please join us if you can. I would like to just end by asking Eric, what is your message to the lymphedema community?
So first off, I would say thank you for this, Jeannette. This was great, and I really appreciate having the opportunity to be involved. My first part of this message would be just the importance of the NLN. As I mentioned, my first NLN was in 2008. I've recognized over the, 12, 13 years or more of being in this industry, just how important the NLN is in tying together the research and the camaraderie and the anecdotal as well as research-oriented understanding of therapists it's an incredible organization, incredibly important, and I really applaud you for what you've done over the last years to continue that forward. So thank you, and thank you for the opportunity. We're proud and grateful to be a gold sponsor this year of the NLN. I will end with, you mentioned two words. You mentioned community and you mentioned empowerment. I think both of those speak very, very closely to Lymphopress's message and to our heart. First is, when you talk about community, we recognize that we are, as we've said a number of times, one piece to a much larger solution. You know, we can never replace any one of those. We're not a replacement for garments. We're not a replacement for therapy. Therapy is not a replace for garments, and garments aren't a replace for compression pumps. We are a solution together, that together we can really provide the best tools for treatment for the patient. And then the last thing is the message of empowerment. And that is absolutely at the forefront of our thinking. Our goal is to empower the patient. Lymphedema, unfortunately, is sometimes a progressive condition. Sometimes it can move through different stages. And fortunately, if we catch it early enough, it's been shown that sometimes we can even reverse it or hold it off from progressing. So our devices are made to be able to provide that level of treatment. So we can treat fibrotic areas, we can modify pressure, cycles, garments, all of these different things to put the power and the tools into the hands of the therapist and in the hands of the patients. So understanding that we're a part of a much larger community, our goal is to empower that community with more tools and better tools moving forward.
Eric, thank you so much for your time today. Thank you for sharing your expertise, your thoughts. I always enjoy our conversations. I look forward to many more. I'd like to thank everybody who stayed to the very end. We always appreciate being surrounded by like-minded individuals who are basically, you know, after the same cause, supporting the same cause. And we are so grateful for your presence, and we're so grateful for your support in any way, whether it's your presence, membership support, conference support, engagement, doing things in your own community, doing things that have a large impact, small impact, all together collectively. I'm very optimistic that we can continue to move the field of lymphology forward. So thank you, everyone. I hope you have a wonderful rest of your summer, and hopefully we'll see you all in October.
Thank you all.
Thank you.